Hello world, my name is Christina Kran from OneHealthLessons.com. Today I have the privilege to talk with Professor Vasan, who is currently based in Australia. He is working at the University of York, more precisely York University, and Australian agency. Hello, Professor, how are you today?
I'm very good. So I actually work for Australia's science agency, which is called CSIRO. And I also have an honorary chair at the University of York in England.
Excellent. Could you please tell me when did you first hear about One Health Lessons?
So I met Deborah in England actually when I was there. So I only moved to Australia 2 years ago. And so when I was in England, we met in one of the Public Health England conferences. So I used to work for the equivalent British agency in Portendown in England. And I was, one of the things that still interests me a lot is antimicrobial resistance. So we were doing some work on eBug, which is a sort of a lessons for children in schools to educate them on why is it important washing your hands, not taking antibiotics for viral diseases, and completing your course and that sort of thing. And she was very interested at the time. She was still thinking about One Health Lessons and so on. So we've been in touch since, and I've been trying to see how I can help this, because I sincerely believe that the children are the future and we really need to focus on the next generation. And they have a lot more awareness. They are much cleverer than us. So it's important to reach out to them. So I'm pretty supportive of what she's doing and want to help out in any way I can. Yeah.
Excellent. I mean, you're right. And I was wondering, what sparked your interest in public health and emergency preparedness? Why basically you chose to study public health? Like, what motivated you?
It's a long answer, I suppose. I've always wanted to be a medic, so I'm not a medical doctor. So I think I'm a scientist, so therefore I decided that I could get into public health, because you don't have to be, it's a multidisciplinary field, so you don't have to be a clinician to practice public health. So I found it fascinating because it's, first of all, it moves away from individual health to population health. And it's about those interconnections between the various, sections of both the society as well as the disciplines coming together to help deliver outcomes that are optimal for everyone. Emergency preparedness is something which I got very interested in when I worked for the equivalent agency in England, Public Health England. And again, it's a very specialist area. So there are only usually one or two agencies in every state that are responsible for this. And it's a great privilege to be part of that sort of a framework. Yeah.
Impressive. So basically, networking in this projects is like in these projects. Basically, it's of a paramount importance. And what do you think about basically the era of COVID-19 and the current vaccines that they are producing?
COVID is absolutely terrible pandemic. I mean, it's affected, according to the WHO, 10% of the world's population, which also means 90% is still susceptible. So we need these vaccines to protect, people who are, many of them, vulnerable, and it's disproportionately affecting poorer sections of the society, and it's widening inequalities. And the other important thing is it's spread to over 200 countries. And we have about 61 million confirmed cases as we are speaking and counting. There are 321 vaccines in development, and some are leading now. So I was quite privileged and lucky to be part of some of the ones that are leading at the moment. So we actually evaluated two vaccines in my facility here. One was Inovio's vaccine, which is a DNA vaccine. The other one is now in the news. It's the Oxford's vaccine, also called the AstraZeneca vaccine. And we evaluated it in my lab both in intramuscular as well as intranasal administration. And we also looked at one dose versus two doses. And it's really heartening for me to see that all that data we provided to them and to the regulators, now they've gone ahead with human trials, and some of the doses are showing up to 90% efficacy. So that's pretty promising. Why are we getting COVID? I mean, that's a complex question. I think it's because we are neglecting One Health, and this sort of thing is bound to happen. It's a matter of more of these sort of pandemics are likely to happen, unfortunately, in this century.
Yes, exactly. And I was wondering, the first theory about COVID-19 was that the virus itself was transmitted from animals to humans. To what extent this theory is true, basically? Like,
I think I certainly think it is true in terms of it's a zoonotic disease. There's just no two way about it. The precise, I mean, it's also reasonable to say, and there is scientific consensus that it's of bat origin. Now, the intermediate host at this point of time is yet to be conclusively established, but we also know there's a colleague of mine in UCL, Francois Bella, who estimates that it's somewhere around October to December is sort of the period when it jumped into humans. And as I was alluding to earlier, we had SARS in the beginning of this millennium. And then in WHO, there was the international health regulations, and there was this concept of public health emergency of international concern. Since 2009, we've had 6 declarations, emergency declarations. We had H1N1, then we had Ebola, we had polio, we had Zika, we had Ebola again, and now we have COVID. And there is also diseases like MERS, which are also of the zoonotic nature, which wasn't declared as an emergency by WHO, but nevertheless, it's equally important. So, Christina, within 20 years, we've had SARS plus 6 public health emergencies plus MERS. So that's like 8 major, diseases. Most of them are zoonotic, and we've had 2 pandemic declarations. So a lot of the emphasis now needs to be towards the animal origin of many of these diseases. And also bear in mind, there are other diseases that are very important, zoonotic again. So you have what we used to call in England the big 4, or apart from Ebola, you have Lassa fever, you have Nipah, and then you also have the Crimean Congo hemorrhagic fever. So sometime, in 2-3 years ago, the WHO came up with a concept known as disease X, which is this next big disease that we don't know what it is precisely, but we know it's going to happen. And many of these are likely to be zoonotic. And the reason for that is because I think we are focusing on human health without sufficiently thinking about animal health and the health of the environment.
Absolutely. Like always, we are trying to portray in the media, especially the needs of the human beings, but not the needs of the animal world, and also the health of the environment. So it's like it's a circular path that we have to present it as One Health. So like One Health combines, as you said, like the animal world, the human health, and plus environmental health. So basically, we are part of this circular natural process. But always human beings tend, always to appreciate themselves much more than the nature. And in 1918, the Spanish flu took place, and there were around three waves with the pandemic. So do you think that for COVID-19 we could eventually envisage a third wave, or everything depends on the vaccines that they are going to be developed and basically sent to the countries in order to give these vaccines to the people? So what's your opinion about this?
This is something we need to wait and see. But one thing is certain, you are likely to have multiple waves, because I'm not even saying three, there's probably going to be more than that, because what you are essentially seeing is that the virus in a new host will mutate. Now, thankfully, this is not your influenza virus. This is an RNA virus, but unlike the flu virus, this has a proofreading mechanism, and it's actually an exoribonuclease. So it means that this virus is not going to mutate as fast as the flu virus. And the COVID-19 virus, which is SARS-CoV-2, is closer in its behavior to pandemic influenza rather than seasonal influenza. Okay, so the virus will mutate, and it will mutate in humans. It will also mutate in animal reservoirs as it finds them, invariably. That's going to happen. Now,
And yes.
no, ask me.
I understand, and I was actually I was planning to ask you, for instance, how can we relate this, with your extensive experience that you have in global health emergency preparedness. For COVID-19, we need to have some sense of preparedness, especially during the second wave. And in your opinion, how does One Health fit into infectious disease control and biosecurity? Like, how can you combine this?
So let me continue the answer to the previous question, and then I will answer this one as well, because it flows nicely.
Yeah.
So the issue is, when you have the virus in a new host, it will mutate, even if it's a slower mutating virus. And you will find that, so far we have tested the vaccines against some of the major mutations. So my lab was responsible for the world's first experimental evidence that the G strain of this virus, which has the D614G mutation in the coronavirus spike protein, that it will not affect the vaccines, or we couldn't find evidence. We also did some computer modeling to show that. Assuming that newer mutations are not going to affect the efficacy of the vaccines, you asked how long will it take and whether there'll be a third wave. The point is, even if all the 4 or 5 major vaccines in the world now, so there's Moderna, there is Pfizer, there's AstraZeneca, which is a non-replicating viral vector vaccine, and then you also have vaccines from Russia, China. Now, assuming all of these are successful and we are able to make them very quickly in large number of doses, and we overcome the challenges with the cold chain necessary to get these vaccines to billions of people now, and this vaccination process cannot happen overnight, right? So this is going to take several years, and the WHO actually estimates that the pandemic may take a good 3-4 years at least to bring under control. So by then, you also find that the virus, when you are starting to vaccinate people, the virus's behavior will also change because of the selection pressure that it's facing. So this is a continuous fight. So the best case scenario is that we are able to vaccinate most of the world's population, and that the immunity conferred by the vaccines are longer lasting, both the two arms of the immune response, and that with the help of additional booster doses and so on, we are able to keep the immunity level under control. And it becomes more at that point, maybe a challenge, a public health challenge similar to the seasonal influenza. Okay. Now, if we get to that stage, that would be very good, in my opinion. Now, you also need good, apart from vaccines, you need good therapies. You need drugs. At the moment, you only have dexamethasone because remdesivir and hydroxychloroquine are not supposedly showing efficacy to the extent we want. And the monoclonal antibody cocktails are very expensive as well, such as Regeneron, for example, and they're not very widely accessible to the world. So this is a big challenge at the moment, okay? So, and this may well drag out for the next 3, 4, 5 years, okay? So you asked me how many waves there will be. There will be, we have to be prepared that there will be not 3 waves, but more waves, okay? Now, the other question you asked me from that was preparedness. Now, a lot of the response, we talked about how we have a very human health centric approach rather than a holistic approach hitherto. And the other approach we also have is a very responsive approach. So, in other words, you have emergency preparedness, resilience, and response. And sometimes it's also called emergency planning, resilience, and response. More emphasis and money has gone towards response rather than preparedness. So when something happens, bad happens, say SARS or MERS, or now you have COVID, a lot of money is thrown at responding to it, which is a very reactive thing to do. Not enough efforts are going into a more proactive, preparatory approach. And so now we feel what might happen is because of COVID, the silver lining is that maybe there will be a greater recognition amongst countries of the world that we need to look at One Health, and we also need to look at planning and preparedness before things happen, rather than worry about what to do when something happens. Yeah. So I do believe that might be one of the good things that comes out of COVID.
Indeed, in this part of the world, in the region where I'm living, in Southeast Europe, we have a saying, like pandemics or every challenges in life, or every challenge in life is like an earthquake. You cannot expect it. You don't know when it will occur. And this is the case with COVID-19. No one expected it. It just suddenly, like, I don't know if I shall qualify it, as a COVID-19 pandemic earthquake, in terms of in scientific terms. So definitely we have some trajectory of as you said, of diseases that are perhaps less spread than the COVID-19, and they are just present in specific country, like it was the case with the Ebola, just was present in African country for a period, etc., etc. You have worked as a trainer for UNDP risk assessment, right? As far as I'm
As well
familiar.
as the WHO TDR. Yeah.
Yes. So perhaps can you tell us more about your experience as a resource trainer for TDR, African Biosafety?
Yeah, so this was before I used to work for the British government agency called Public Health England. I used to work for Oxford and its spin out called Oxitec, which is now owned by an American company now. So it's a big operation at the moment. But when I worked for them, they were part of the university spin out ecosystem. And at the moment, I'm working on viruses like polio virus and the novel coronavirus. Uh, Previously, I used to work on other viruses, particularly arboviruses like dengue, chikungunya, and Zika, and so on. And we formed this company in Oxford with the technology to control dengue fever and chikungunya and so on. And it was one of the interesting cases where the technology was way ahead of the regulatory system. So there were not sufficient regulations in place for the technology. And the other challenge was that the biosafety awareness and training and capacity building was also not uniformly to the same standard in different parts of the world. So the WHO under the TDR program recognized this, and they set up a call for Asian, African, and Latin American biosafety training network. And I was actually associated with both the Asian and the African one. And I was the co-principal investigator of the Asian Biosafety Network, which was hosted in India. And there it ran for 3 years from 2009 to 11, something like that. And we had a number of people at the level of professors, associate professors, heads of laboratories from different countries in Asia come to India and get trained for 2 weeks. And this was a major capacity building exercise. The same happened in Africa, in Mali at the University de Bamako. So I used to go there and teach, and it was a great experience. It's a great country. And we used to have both Anglophone and Francophone countries in Africa who used to come there. So I used to have my slides in French and speak in English because I had to teach to an audience which involved both French and English. And it really helped reach out to these African universities. And there is so much of capacity already in those countries and so much willingness to improve the state of knowledge and biosafety awareness. And we were able to bring them together and share learning. And what I found really good about it, Christina, is that it's not just us teaching one way. We also learned a lot from them. So knowledge sharing is never one way. So I came out probably learning more about some of the fantastic things they have, on the scientific front in Africa. And also participants learned from each other. The UNDP you are talking about is a risk assessment workshop which we ran in Malaysia. And that was specifically around the transgenic technologies to control arboviral diseases. And there, the focus is not on biosafety, but the focus is around risk communication. So it's one thing when you talk about risk, particularly biorisk, you have what you call biorisk, understanding what risks there are, mitigating the risks, but then often people stop with that. But there is a third step without which it's incomplete. The third step is communicating the risk to the stakeholders. So we focused on that. And talking about biosafety, later I also worked with a project funded by DFID through the Tropical Health and Education Trust. So we established a biosafety collaboration network in India with Public Health England. So I believe these kind of initiatives from a One Health perspective, we need more of these initiatives, particularly focused around zoonosis. Now, I want to touch upon a point you made in the last question, which is that you said, it's like earthquake, nobody expected this was going to happen. As a matter of fact, we knew this was going to happen. We just didn't know when, and we didn't know in what shape it would be. But the concept of disease X is the recognition that something like this will happen. We had a fairly good idea that coronaviruses are one of the likely candidates, and bat-borne diseases are still a major threat to humanity in this century. So it's not like it's completely unexpected. It's a bit like if you are living in an earthquake prone area, you know there will be an earthquake. You just don't know where and when. So you got to be more prepared. Yeah. But
Yeah.
it's a great analogy. I like your analogy because it's very apt. You just don't know where and when, but you know it's going to happen. Yeah.
Actually, I'm living in Istanbul currently, and every scientist that has analyzed the seismologic activities in Turkey, basically, they say that basically we should be aware that one big earthquake will happen in Istanbul, but it's a matter of basically we should be ready because it can happen in any minute. And recently we had an earthquake in Istanbul, in Izmir as well, yesterday in Malatya in Turkey. So basically it's a region that is prone to seismologic activities, and that is actually um, giving some is giving us some feeling of fear, but at the same time you say like we have to cope with that. If it happens, we have to cope with that. And now coronavirus happened, we have to cope with that. So that is basically what I meant when it meant, like we don't know when and how, like an earthquake. I have one more last question for you. It is like, you have watched already the YouTube COVID-19 lessons for children that are prepared by One Health Lessons. And in that videos, the teachers are speaking, or the mentors are speaking about mutations and how the virus is transmittable from a person to a person or from an animal to a person. And basically, if we are now talking about children, um, what kind of advice will you give to children and perhaps students of my age about perhaps bringing science more to classrooms? Because personally, when I was younger, we studied about, epidemics, pandemics, but never the professors will say, like, oh, we are expecting that a new pandemic will happen in 30 years or 40 years. They're just generalizing. We are just studying the trajectory of pandemic diseases or in class of biology, but really we don't have in this part of the world something relatively about science, specific oriented. That's the formal school curriculum. So how can we bring more science to classroom? How can we develop it and make it more accessible for students like me and children as well?
Firstly, I think scientists have an obligation to communicate, and it doesn't come naturally to all of us. I'm no expert in that, and there are much better science communicators. And but all scientists who are at the forefront of science, even if you are not a great communicator like me, you still need to make an effort to come and talk to people. Scientists are also people. In the end of the day, we go home, you're a father, you're a teacher, you have your daily job, you're a neighbor, and you got to reach out to people and try and explain what is it you're doing. Okay. And nowadays there is social media and there is blogs and there are various news items where scientists are being interviewed. And I hope that can hopefully, demystify science, that not all scientists are running around with lab coats all the time. We all have a normal life. and we are also sharing the same anxieties as the rest of us, right? But there is one crucial difference between scientists and maybe the general public. I love a quote by the Nobel laureate Marie Curie, where she says, "Nothing in life is to be feared, it's only to be understood." So when you are living in a pandemic and you are living in uncertain times, it's very natural. All of us feel that, right? So we feel afraid of our own future, what's going to happen, and our job safe, so on and so forth. But when it comes to science, when it comes to understanding diseases, we scientists, we're not afraid of the virus. We have the necessary tools, the biosafety techniques, we have the necessary capacity, training, labs, infrastructure, to and the knowledge to work with these unknown viruses. We didn't know much about SARS-CoV-2 a year ago, yet we now know a lot. And now working collaboratively, scientists are able to learn from each other. So one of the key messages I will say is that the important thing about scientists is that we're not afraid of the virus. We want to understand it. We believe that by understanding the virus, we don't need to be afraid of it anymore. And we can actually find cures, we can find vaccines, we can test them, we can understand how the virus is mutating, we can be better prepared for the future. And the next time this happens, we will be so much stronger. And children actually can play a major role in this. You are never too young, right? So a lot of work which I'm doing involves the interplay between traditional molecular biology, clinical medicine, but also computer science. So I work with Data 61, which is the CSIRO's high performance computing division. I work with transformational bioinformatics. So these are people who are very clever with their computer skills. And you know what? Kids are great with computers, right? So they are much better than us grown-ups, right? So there is a growing movement to involve children in high schools and so on as interns to come and help out in these science projects. So if people are interested, they need to write to your own science agency. Wherever you are in the world, every country has a science agency. In Australia, it is the CSIRO. You will have, you have the CDC in the US and so on. So you can write to them and you can say, I have these skills and I would like to contribute. How can I contribute? Talk to your teachers. If you're really good, your teachers can put you in touch. So I think it works both ways. We can come and talk to you, but I also think we have so much to learn from children as well. They are so, my 10-year-old daughter is much better at computers than I will ever be. So, so I think we have a great future there. Yeah.
Yes, you're right. And I truly hope that One Health as a concept will be presented in front of the school curriculums, and perhaps to be able to share this idea with not only young children or not only young children, but also with students of my age, and also with our elder members of our families, like grandmas, grandpas, and also they need to be informed about what's happening, because for old people especially, it is very difficult to stay confined at home for a long period of time. So my grandma is saying, like, I cannot imagine. I cannot imagine staying at home. I cannot believe that I stayed at home for 6 months confined. I'm a person who would like to stay, all the day in the garden. She's gardening and she's taking care of her flowers. She said, I grew up in the field. I can't be at home. So we definitely need to support our old elder members of our families as well, I think. All right. We are facing internet Wi-Fi problem. So yes. So I would like to thank you for your time, and hopefully to talk to you soon. It was a very informative talk, and thank you very much. Do you have any questions?
No, I do have one thing to say, which is all the best. What you guys are doing is awesome, and it's so important initiative. Developing the One Health curriculum for schools and making them available. So I'm very proud to be associated with your venture, and more than happy to have had this chat. Thank you.
Thank you. Thank you to you too again. Take care of yourself and greetings to your family and friends as well. Bye-bye.
Bye bye. Merci beaucoup.